thanks to Sharda Jain ma'am for having faith in me in absence of Dr. Jyotsna. She was supposed to be here as a moderator, but she couldn't make it. She was out of station. Thank you so much, ma'am. And we are, I think like we were since morning, we were feeling max self in between PPH, but I think it's going to be a good break for everyone from PPH. And this is also one of the very important obstetric emergencies, as we all know, which we are going to discuss. And we'll just try to, we have tried to, put up certain situations which so many of you encounter in your day-to-day practice, that how to handle those situations. And our respected chairpersons are also there to add on to their expert opinion if we miss out on anything. So we all know how important magnesium sulphate is, and one important thing is this is also high alert medication, because if not used with care, it can cause much damage also. So we start we all know magnesium sulphate for eclampsia. Now we know other uses also, but just to highlight again, and I have with me Dr. Divya. So we are just going to have it in a dialogue form, so it is not monotonous also, and so that we can dig into it and just bring more facts in front of you. So Divya, could you just highlight the various uses of magnesium sulphate which are
so everybody knows magnesium sulphate use in obstetrics. It is mainly used as anti-seizure medication, especially in pre-eclampsia with severe features and eclampsia. Apart from this, we have neuroprotective role of magnesium sulphate for preterm babies and tocolysis action also.
So just one small thing about how it prevents seizures. We'll not go into much detail of it, that what is happening, but just how it is going to prevent, because it is not anticonvulsant drug. We don't give it in epilepsy, but it is very commonly given for prevention of fits in eclampsia. So what actually it does to the patient?
It is actually used for prevention of recurrent seizures rather than control of the initial seizure. It is a very important point, and the mechanism of action by which it works, by decreasing the neuromuscular transmission and decreasing the CNS irritability, and also decreases intracranial edema. And we have to know this fact that 10% of patients with eclampsia will have repeated seizures if managed expectantly. So it is very important drug for prevention of recurrence of seizures in eclampsia.
So now one very important question comes is, if it is not going to control the current seizures, so when patient is convulsing in front of you, should you give Maxil? Because it is a very short lasting convulsion. So by the time you prepare any drug, the patient has stopped convulsing. So you can give Maxil even if patient has had convulsions in front of you, because most of the times previously we used to say give diazepam then Maxil, but we should not add on to more respiratory depressants. So by the time you load diazepam also, patient is going to stop convulsing, so it is better to go ahead with Maxil. So because we are giving it for prevention of next convulsion. So then it does have a role in severe preeclampsia also. So Divya, could you just please highlight that what is its role in severe preeclampsia, and importantly, as we were talking about counseling of the patient. So eclampsia, you give Maxil, it is very clear that you are giving it for the purpose because patient is already having convulsion. But when you are giving in severe preeclampsia, maybe you have to do better counseling of the patient, have to tell them that why you are starting this medicine.
So let us see what is the basis of the counseling when we are dealing with such patients. We all know that now there is a very strong recommendation level A evidence of its role in seizure prophylaxis. This is the famous MAGPIE trial, which was published in Lancet 2002, which came out with the fact that if we use magnesium sulphate in patients with severe preeclampsia, it reduces the risk of convulsions to 50%. Moreover, it decreases the maternal mortality by 1/3, and in addition to this, the complications like abruption, they are also reduced to about 1/3. So it is very important drug of choice, in fact, for the control of recurrent seizures.
And also to continue this for 24 hours in the postpartum period, because 27 to 65% of eclampsias occur in the postpartum period. So just don't stop when the patient has delivered. Even in cases of severe preeclampsia, continue Maxil for 24 hours after delivery. So now next thing is various regimes of Maxel. We all have been reading this Pichard regime, Zuspan regime, Sebai regime and Dhaka regime. So it is, why we need to have so many regimes in places, and this is because there is evidence that whatever Maxel we are giving at this concentration, even a concentration lower than this also, seizures can be prevented. So there was, people had worked on the lower doses of Maxel also, and second thing is even at therapeutic doses also the patients were having convulsions. So various regimes, high dose, low dose were tried, and out of which Pichard's is the most common one. So could you just highlight this?
So this is the most commonly regime which we are using. It is a combination of intramuscular and both intravenous route of administration, where we are giving loading dose of 14 grams, 4 gram of which is given in 20% solution intravenously over 5 to 10 minutes, and then it is followed by intramuscular injection of 5 gram in alternate gluteal region, and maintenance doses again 5 gram of 50% solution in alternate gluteal region every 4 hourly. And it is very important to know that when we are giving the drug IV, because of its thrombophlebitis potential, it has to be given in low concentration. That is the reason we are giving it in 20% solution for IV injections. For intramuscular, we use 50% solution. Then we have, besides Pritchard regime, we have low dose IV regime also, of which the very famous regime which is being followed is Zuspan regime, where we are giving completely IV route of administration is followed. Here the loading dose is 4 to 6 gram, 20% over 5 to 10 minutes, and maintenance dose is 1 to 2 gram. 20% solution. Now this is, we can decide upon the dose between 4 to 6 hours, the loading dose 4 to 6 grams according to the body weight of the patient. Another regime is Sebai regime, which is 6 gram loading followed by 2 gram per hour, and a low dose regime, Dhaka regime, where the loading dose, in spite of 14 gram what we are giving in Pritchard, here we are giving 10 grams, 4 gram IV loading and 3 gram intramuscular, followed by maintenance of 2.5 grams in alternate gluteal region.
So Zuspan, if we are giving 4 gram bolus and 1 gram hourly, then it is a low dose. But if you are giving 6 gram and 2 gram, which is also Sebai regime, then it is, high dose, higher than the Pichard's regime. So this is one thing which we have to keep in mind. And there was just one study which was published in 2021, although I don't know, the power of the study was not calculated, but it was done on patients. They had given the Pichard's regime and the Dhaka regime, and they found equal results in both. But I remember when at Safdarjung Hospital this trial was started way back in 2000, there were more recurrent convulsions with the Dhaka regime. So we have to probably wait further also for more studies to come comparing these two. But in Bangladesh they had seen good results with this. So this study also concluded that probably for Asian population we may not need that higher doses which are there in the Pichard's regime, but too early to draw any conclusion. But yes, even the low dose Zuspan which has been studied, and there are not much comparative studies between Pichard's and Zuspan, but all the regimes, they have shown to have good result, because the monitoring which is continuing. So and you can always repeat Maxel if the patient has convulsions, which we are going to talk about. So now very important thing, the onset of action and duration, because one very common nowadays, this mistake is not happening because everyone is very comfortable with giving IV Maxelf, and I think probably this 4% coming up, people will be more liberal further in giving IV Maxelf. But then they were thinking that IM is safer, like we use Pichard's, like till last time also when we used to discuss in conferences, even in the practice, because these IM injections, 10 ml giving to the patients IM, are very bulky injection, and patient has this pain, and also in practice you have to make your patients very comfortable, but people are worried to use Zuspan regime. So just to highlight that and to make you more comfortable with that regime. So various routes which are there, the duration of action and the onset of action.
So when we are using magnesium sulphate by IV route, the onset of action is almost immediate and it lasts about 30 minutes. But with intramuscular route, the onset takes around 1 hour and duration of action lasts for 3 to 4 hours. And it has been seen that adverse effects and the pain is more with intramuscular route. That is the reason Zuspan regime is now coming up, and it is choice regimen for the practitioners nowadays.
So basically, if you are giving Zuspan regime and patient has respiratory depression also, you know the duration of action is 30 minutes. So I think it is much safer than giving IM. So though we at our hospital, we do not have so many infusion pumps available that we can give patients, all the patients by Zuspan regime, but it is much, much safer, and I think people who want to shift can safely shift to Zuspan regime. So next thing is, this is very important because maybe now we have this injection magnesium, that how to prepare IV Maxel, but just to highlight, because at some places we'll continue using this. So how do we prepare the magnesium?
In public setup, in our government setup, we are having this kind of ampules of 10 ml solution which contains 5 gram of magnesium sulphate. To prepare 4 gram of IV loading dose, we have to take 8 milliliter or 4 gram of magnesium sulphate, which is already 50% solution available, and then dissolve it in 12 ml of sterile water to make a solution of 20%, and this has to be given over 5 to 15 minutes slowly. Then for IM preparation, the one ampule is already containing 5 gram of 50% solution. It can be given intramuscularly. But here the word of caution is we have to use it with 1 ml of 2% lignocaine, because these injections are really painful.
So when you are loading the injection, load Maxel, then take 1 ml of lignocaine, 2%, and so that when you are giving it, the lignocaine will go first. So this is important, that don't load lignocaine before, load it in the end. So, and one important, very important thing is, these patients will need other supportive treatment also. So it is not only giving Maxel. So just one slide about it. So can you please
So we all know supportive care given for the patients who are on magnesium sulphate. Their airways needs to be secured. We should prevent tongue bite during the seizures. Oxygen therapy should be given, and we should be following 3 hours while monitoring the patient who are on Maxel. These 3 hours are respiratory rate more than 16 per minute. The renal output, the urine output should be more than 30 cc per hour or 100 ml in last 4 hours, and the reflexes, the deep tendon reflexes should be present. And apart from this, the patient should be given antihypertensive. It is a very important point that magnesium sulphate is not an antihypertensive agent. So we have to supplement antihypertensive agent along with the magnesium sulphate. And it has to be continued after delivery or after the last fit, whichever is later.
So although we say respiratory rate more than 16 per minute, we know depression less than 12, but 12 to 16 is the window. So you have to be careful in between 12 to 16 respiratory rate per minute. So now we'll discuss certain situations which we commonly come across. So Divya, there is a patient who comes and like after step, just making her comfortable, you had catheterized, she is severe preeclampsia, so you didn't give Maxel first and no urine output is there. Or maybe even if she is eclampsia, she has come with a catheter and catheter is empty. So what will you do? Will you give Maxel to her?
So it is a very important point to note here that the initial loading dose, for giving the initial loading dose, we do not require any urine output, or it can be given irrespective of the renal function. So first loading dose has to be given because the volume of distribution remains the same. But for the further maintenance dose, we have to titrate the dose, or we have to think upon whether to continue the dose according to the urine output or creatinine levels.
So this is probably not for the same patient, because she has no urine output. You are observing her and you are keeping in mind maybe her renal functions are also not good. So you have to calculate the creatinine clearance for further injections. But any patient who is on Maxel, the convulsions recur. So what will you do?
If we have already given the patient the loading dose and there is recurrence of seizures, we have to give 2 gram of 20% solution over 5 minutes, and it can be repeated. We can give 2 doses of such 2 gram magnesium sulphate for the recurrent seizures.
So now, given again, or maybe the situation is such that you cannot repeat magnesium sulphate, like you are not sure about her creatinine clearance. So what will you do in those cases? Or maybe if the patient is convulsing again and again in front of you, not getting control, so immediately what will you do?
So let us see first what is magnesium resistance, magnesium sulphate resistance. If the patient is still continue to seize at 10 minutes after the bolus injection of magnesium sulphate, or there have been 2 recurrences, then it is called magnesium sulphate resistance. And here we have options of giving them benzodiazepine. The various drugs which are available are lorazepam, midazolam, diazepam, clonazepam. They are all available in these cases.
So many at times, because we have shifted to midazolam now. So midazolam versus diazepam, we just wanted you to know what are the advantages of midazolam over diazepam.
So midazolam has its own advantages over diazepam. It has more rapid action, more rapid elimination. It is more potent than diazepam. It has better affinity and it is less painful. So we can give 2 milligram of IV, slow IV injection of midazolam if the patient is continuing to seize even after magnesium sulfate.
So these patients, we know we are finally going to take them to OT, maybe do cesarean, terminate immediately the pregnancy, but then, or maybe put them under general anesthesia if she's already delivered, but then till then you need something. So midazolam, because it has a shorter duration of action, even if respiratory depression occurs, the effect will go very fast. So we have now shifted to midazolam, we don't use diazepam now. So any benefits of non-diazepam anti-seizure medications?
So now we have to take into account that when we are giving benzodiazepine, they have short duration of action. So they have to be supplemented by other anticonvulsants. So other anticonvulsant non-benzodiazepine preparation which are available are phenytoin and levetiracetam.
So before we go on to the full dose, let's talk about the contraindication and complications of Maxil. So as we said, it is not a drug which is without complications, and though very few, but there are contraindications. So just to highlight that.
So absolute contraindication to use magnesium sulfate is renal failure, hypocalcemia and myasthenia gravis. And complications which are common with magnesium sulfate, we have to be really cautious while giving magnesium sulfate. Are pulmonary edema, respiratory depression, cardiac arrest, and profound muscular weakness.
So renal failure is basically contraindication for the maintenance dose. Loading dose can be given with renal failure. So now the severe preeclampsia patient has come, BP is very high, she also has severe acute hypertension and she has pulmonary edema. Will this change your line of management?
See, if you see this patient, she is severe preeclampsia with acute severe hypertension with pulmonary edema. This patient is already having pulmonary edema. She is at more risk of throwing a convulsion. So we have to be cautious regarding giving anti-seizure medication to this patient. So first action while managing this patient will be to control the acute severe hypertension. We have to take care of her high blood pressure by giving antihypertensive and diuretics because she is in pulmonary edema, oxygen therapy, supportive treatment, and see if the pulmonary edema is getting resolved. If it gets resolved, then we can give Maxil. If it is not getting resolved or respiratory depression ensues, then Maxil becomes a contraindication.
So this basically we highlighted because many patients who have severe hypertension, they will be requiring Maxil therapy. So there, and Maxil, one of the complications of Maxil which we highlighted is also pulmonary edema. So you have to be careful in these patients, but all these patients do not have contraindication to Maxil. If it is just that you have given them diuretics, the Lasix has been given and you give antihypertensive, it resolves there in the emergency itself, you can give Maxil, but you have to be careful in these patients. So just to highlight that, we had put in this case here. So now after other anticonvulsant therapy, can Maxil be used? This is about the phenytoin, and now we just wanted to discuss the dose and all, as we have already talked about the other drugs which can be used. So just to see that what are the doses of these medicines which we can use other than Maxil if we have contraindication, or maybe in pulmonary edema you don't want to start magnesium sulfate.
So here we have two drugs, phenytoin and levetiracetam. Phenytoin, the indications, as you can see, it is recurrent seizures or magnesium contraindications or seizures which are not getting controlled by magnesium sulfate. Here the loading dose is 15 to 20 milligram per kg and maintenance is 100 milligram 6 to 8 hourly. And second option is levetiracetam, where the loading dose is 1000 milligram followed by 500 milligram daily. Maximum dose of 3 grams, but here a word of caution, this drug has renal excretion, so dose titration has to be done according to creatinine clearance.
So it is basically that you start it, and for further giving repeat injection you should know the creatinine clearance. Serum creatinine should be known for this. And Now, because we were talking about pulmonary edema, so this is one condition where we do not use the usual antihypertensives which we are giving. So, what antihypertensive we should give in patients who have hypertension
So,
with pulmonary edema?
in these patients, labetalol is absolutely contraindicated when the patient is coming in pulmonary edema. Here, the drug of choice becomes nitroglycerin. It has to be given in the dosage of 5 microgram per minute every 3 to 5 minutes up to 20 mics. Then it can be increased by 10 microgram per minute.
But it should not be continued continuously. You know that you have to give some other longer acting antihypertensive along with it. So just don't stop by giving this. You have to add on other antihypertensive. So if labetalol is also contraindicated, and we know that previously nifedipine was to be, we were told that it should be avoided. So is it still true that we should avoid nifedipine when we are giving Maxilf?
If we see the mechanism of action of nifedipine and magnesium sulphate, both of them are calcium channel blockers. So it is perceived that they will lead to increase in the neuromuscular blockade. But studies have now proven that if they are used together, then the risk of neuromuscular blockade is only less than 1%. So they can be used together, but we have to keep the patient under monitoring. If we see the sign of toxicity or respiratory depression, we have to keep the antidote handy.
So another thing is, don't give sublingual nifedipine. That is important. It has to be given by oral route. That is why you have to give some other antihypertensive with nitro, we are giving nitroglycerin as emergency hypertension, and nifedipine oral can be started with that. So now this is one patient who is a known case of chronic renal disease in pregnancy, and with the serum creatinine of 2.5 milligram %. Now she develops preeclampsia with severe features at 34 weeks gestation. So will you give her Maxilf?
So as we discussed earlier, the first loading dose has to be given irrespective of the renal condition or no urine output. The first full loading dose has to be given because the volume of distribution remains the same. But later on, for the maintenance dose, we have to see the creatinine levels, and accordingly we have to titrate our maintenance dose. So if the serum creatinine level is less than 1 milligram per deciliter, we can continue with the same maintenance dose. It is between 1 to 1.5, we can halve the maintenance dose, that is 1 gram per hour. And if it is more than 1.5, withhold the maintenance dose and go for other anticonvulsants which are available. And these patients need serum magnesium level monitoring every 4 to 6 hourly. This is very important.
So now this is one patient, like you were giving magnesium sulphate, and very commonly it happens that when you assess deep tendon reflexes, they are absent. So what should be done?
Absent deep tendon reflexes is the first sign of magnesium toxicity. If we are finding such thing, we should withhold the maintenance dose, continue the clinical monitoring of the patient, and as soon as the tendon reflexes they reappear, we can continue with the maintenance dose.
And very important here is, because many a times it happened because people feel it is magnesium sulphate toxicity, they give antidote. It is not to be given if the tendon reflexes are not there. You just wait, assess patient every hour till the time tendon reflexes is not there. It means the levels are there, but these levels are not too high that you need to give antidote calcium to these patients. So this is one very important mistake which many people do. Even our resident also at times, it is their first reaction, tendon reflexes nahi hai to dena hai ya nahi dena. So it is not to be given, and you don't have to give any other anticonvulsant also. There is no need to shift on any other anticonvulsant. The levels are maintained, and this patient will not require further addition of other drugs. So this is a patient who is now drowsy, and respiratory rate is 10 to 12 per minute. So what will you do in these patients?
Now this is the patient who has developed profound magnesium toxicity. This is the patient where you will go for antidote, which is calcium gluconate, 10 gram of 10% solution over 10 minutes. And this usually reverses the mild to moderate respiratory depression. But if the respiratory depression is of severe category, then you have to go for prompt tracheal intubation and mechanical ventilation as a life-saving procedure.
So just one slide to tell you what are the levels of magnesium sulphate, and at what level you will see the toxicity of the magnesium sulphate. And should we do magnesium levels in all patients in high resource? Because here many of you are from the settings where the patient can get it done, but should we be doing it routinely or not?
No, it is not recommended to do routine magnesium level measurements. Only in the setting of renal impairment or development of magnesium toxicity like respiratory depression, we should go for magnesium levels. And here we can see the therapeutic levels in millimoles, milliequivalent, milligram per deciliter. We can have this chart handy because the lab reports are coming in these units. So we should know all the values. The therapeutic range is 4 to 7 milliequivalent per liter. More than 7 milliequivalent per liter, we have loss of patellar reflexes. More than 10 milliequivalent per liter, it leads to respiratory paralysis, and more than 25 cardiac arrest can ensue.
So magnesium levels to be done every 4 to 6 hours only if serum creatinine is more than equal to 1 milligram %, or patient is showing signs of respiratory or cardiac depression. Otherwise, we should not be doing these levels. So I have just written neuroimaging because what neuroimaging you do depends upon your setup. Like we are at resource limited settings, so we will do CT, but few people have facility for doing MRI also. So what are the indications for doing neuroimaging in these patients?
We should go for neuroimaging when we are thinking something some intracranial event has taken place, and these situations are status when the patient is having recurrent seizures. She is in the state of status epilepticus. The magnesium sulphate is not working. She is having recurrent seizures even on magnesium sulphate. There is prolonged post-ictal phase or persistent headache or focal neurological sign. Then we should go for neuroimaging.
So another very important, so we have done with eclampsia. So questions, I think if you want any question, because we have kept it very short, otherwise we'll be finishing it in time. So if anyone wants to ask, yeah, you have already crossed, so we can have it later. So now magnesium sulphate for neuroprotection, because this is one area where few of us are not sure when to give, how much to give, till what time to continue, and if patient does not deliver, then what to do. So just continue with the what is the mechanism of action in brief and all.
So magnesium sulphate for neuroprotection is used for the preterm babies for prevention of cerebral palsy later on, and the mechanism of action, you can see it has vasodilator effect on the cerebral blood vessel, anti-inflammatory effect in the fetal cerebral brain to reduce the cerebral cell death due to inflammation, and it down-regulates NMDA receptors. Overall, it is leading to giving protection to the cerebral cortex of the baby, and it leads to prevention of very important condition of cerebral palsy. So it is recommended to give it as neuroprotection. Now the FIGO has come up with 2021 this latest guidelines for neuroprotection, where it says that it has to be given, all the previous guidelines were saying it has to be given till 32 weeks, but FIGO 21 says it can be considered between 32 to 34 weeks also. So this is a new thing which has come up. And when to give, what is the optimal time for Maxsulf administration? FIGO recommendation is administer Maxsulf when you plan early preterm birth or it is expected within 24 hours. When the birth is planned, magnesium sulphate should commence as close as possible to 4 hours before birth. But if the delivery is imminent, even then you should go for it. It will at least have some beneficial effect. And a very important line which we came across while going through up to date, they say 6 to 12 hours of maintenance therapy prior to a scheduled preterm cesarean birth will be helpful in preventing cerebral palsy.
So there is now this controversy 4 or 6 to 12. So anyway, you can give it for 24 hours also if required, so that you can decide.
The regimen remains the same, 4 gram of loading dose, 1 gram per hour maintenance dose is IV infusion, and continue the regime till birth or till 24 hours if patient remains undelivered.
So this is very important because they said neuroprotective effect of magnesium sulfates are secondary to residual concentration of drug in neonate circulation. So you have to continue till the patient delivers. So just because many a times people give IV bolus and then stop it. So you just have to continue with 1 gram IV hourly. That has to be continued.
And monitoring remains the same like we do in eclampsia or pre-eclampsia cases. The 3 hours we have to follow, and there is no need of routine serum magnesium monitoring at this dose. And magnesium, the dosage, this is irrespective of the cause of the preterm birth and the number of fetuses. It has to be same for multiple gestation also.
So then just in short about magnesium sulphate as a tocolytic, we all know that we are not using it because we have other drugs available which are better, more effective than this. But it was recommended, and when it was being given for preterm labor, it was said that it should not be given for more than 5 to 7 days because it can have adverse fetal effects also. But anyway, we are not using it, so I'm not going in details of it. The doses, they remain the same as they are being given for eclampsia or neuroprotection. So now coming to the other important consideration for magnesium sulphate therapy, very important thing is that you must inform your pediatrician that magnesium sulphate has been given, because the baby can have hypotonia or even apnea, so these babies may need resuscitation at birth. So this is very important. And coming to the fetal and maternal side effects, so just that baby will take some time to establish respiration, can be lethargic, suckling can be poor, so needs monitoring. And if it is given for more than around 5 to 7 days or more, then the baby can have skeletal adverse effect because of hypocalcemia and hypermagnesemia. And the maternal side effects, most common is flushing, which many of you must have seen, especially when you are giving in patients of pre-eclampsia with severe features with the IV dose. But then you can, just increase the duration over which you are giving this dose. The flushing will not take place. And for rest of the side effects, we are going to monitor the patient. So take home message is, it is a life-saving drugs, but you have to give it with caution. There are very few absolute contraindication for giving loading dose. So it is very important that when you have a patient like this, you can give loading dose. Then by that time you can decide, because our eclampsia trays have only this anticonvulsant. We don't keep generally other anticonvulsants in it. Give full loading dose before shifting. Duration of action, you should remember, for IV it is only 30 minutes, so there should not be any inhibitions for using IV drug. And neuroprotection, less than 32 is established. Between 32 and 34 you can individualize the case. Thank you so much.